have several types of injury due to electrosurgery. Most common one of them is the direct application because of the lateral thermal spread. This is something that has nothing to do with coupling. Coupling means some of the energy from the electrodes have transferred to somewhere else. Okay, not thermal spread, not a thermal spread. So what is the difference? Let's see. We have the direct application here. This is because of, you can see I have a new share. Can you see it, guys, or not? Okay. Lateral thermal spread, lateral thermal, the heat. This is the direct application. Simply because you are near structures, vital structures. While you are using the diatherm, you are around vital structures. So you need to make sure or bear in mind that there is some heat coming out of the diathermy while you are working. So try to secure hemostasis near such structures. If you are going to do hemostasis, don't use diathermy in nearby vital organs. Like, for example, in the vaginal vault, in this case, in the scenario we have, it's not the best thing to use diathermy. Use staples, use sutures, use a clip, because you know that a ureter is running there. If you have a bleeder and it's not controlled easily, use sutures, not diathermy. Why? Because you know that there is high risk of thermal spread and it can go to the ureter. So can you imagine if you have repeated application of the diathermy over the same spot over and over? That means that definitely are going to hurt the ureter. You got it? Got it, guys? Here are the factors that affect the lateral thermal spread according to which type of diathermy you are using. It will differ, yes, of course. Again, you have what we call tissue compression. Tissue compression is a very important factor. How so? If you are applying the monopolar diathermy, for example, and you are applying it to a pedicle, for example, vascular pedicle. If this vascular pedicle is narrow, the lateral thermal spread is going to be high. Why? Because the area of the pedicle is small, so it's going to make the thermal energy go faster from it to a nearby organ or a nearby structure. But when the pedicle is big, okay, it will make the lateral spread less. Here we have what we have, the tissue compression. What is tissue compression? If I'm having low tissue compression, I'm not holding the pedicle appropriately. I'm not seizing or closing over the pedicle correctly. The lateral thermal spread is going to be high. Okay? If I'm doing high tissue compression over my vascular pedicle or adhesion, I'm sealing the pedicle. So, of course, the thermal spread will be low. You got this point? Dr. Fatima, you can leave and join again. So this is simply what tissue compression is. Very logically, if you have a high voltage, you are going to have high risk for thermal spread. You are going to have a continuous current or many applications, you are going to have high thermal spread. Longer application like here. Okay, what else? This is direct application. Okay. So, somebody write to her in the chat box that she can leave and join again. We have what's called residual heat. Residual heat is simply the amount of heat that remains in the diathermy even after deactivation. Just like when you are cooking in a pan. The pan is going to be hot even after you stop cooking. This is residual heat. Okay, so you should avoid touching vital structure with a tip of electrosurgical device immediately after deactivation. You should wait until it cools down. This is simply what is residual heat is. Insulation failure. Insulation failure is one of the common complications during diathermy, especially in laparoscopy. Why so? Because we are talking about a breakdown in the insulation layer around the active electrodes. So I need this. The port that I'm having the diathermy within it. If I'm having a breakdown in this insulation, some of the energy is going to escape and cause damage to a nearby structure. What is the difference between this and capacitive coupling? Big difference. I will tell you why. Insulation failure, mainly, you can see it. Mainly, or you can detect it. Because it's going to be underneath the area you are working in. Capacitive coupling is outside the reach of your eyes, or you can say outside your scope, your working area. I will show you how. See, so here, this picture can come in the exam. Yeah. How I know that this is not capacitive coupling? Because capacitive coupling is not going to be here. It's going to be up, where there is combination between the plastic wrap and the metallic wrap. So it's not here. It's above. Where it's here or not. Forget about the antenna coupling. Okay, I wish I have a picture here. I don't have a picture. No, I will, I think I have another presentation other than this. Anyway, yeah, okay, here. This is the active electrode. This is where, this is where the insulation failure happens. Okay, but capacitive coupling, the problem will happen here. The area between the conductive shield or the insulation here, and the active electrode. This very area. The energy is collected up because there are two physical difference between the active electrode and the insulation material. One is plastic and one is metallic. This is going to make the energy pack up here, collected, and once you turn up your device, this energy is going to escape to a nearby organ. So the injury is not going to be collected by your eyes at once because it's outside the scope of your working area. Not like the insulation failure. You are working here. This is where you are doing the hemostasis, for example. If you have insulation failure, it can happen here, or it can happen here, or it can happen here, but not very above. If it happened very above, you are very unlucky, okay? You are not going to detect it unless the people of maintenance do some tests for the electrode and figure out that there is insulation failure. It's not capacitive coupling, it's insulation failure. Now we have a device that can prevent this, which is called active electrode monitoring. What is active electrode monitoring? It's a device that can detect that there is insulation failure or capacitive coupling, and it will beep, teet, 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 when there is insulation failure or the energy is collected up here. Once the shaft here, for example, you are having red covering for this active electrode, or black one. So once the inner one appears, you are going Okay, again, what is the difference? A difference between insulation failure and capacitive coupling, because both of them are going to give me the same result. I'm having an injury in a nearby organ, right? So you can detect it if the insulation failure is big, okay, or if it's near the working area you are dealing with. If it's far from the place you are working with, it will be very difficult to distinguish between them. But when you have intact electrode, the insulation of the electrode is all good. There is no defect in the insulation. So this is capacitive coupling. How the bowel is injured, or how the bladder is injured, or whatever. If there is no insulation failure, then how? By capacitive coupling. Now we have a device, as I told you, that can detect this, and it will beep. And another thing is, simply, if you have electrode like this, and its covering is in black, like the previous picture, and then you have find a yellow area, this area became yellow, that means that the outer wrapping, the insulation, okay, have been exposed. It is now exposed. Got it? Got it now? By the way, in the CPD question, there is a question about the active electrode monitoring. This technology, which kind of complication it will prevent? Insulation failure and capacitive coupling. It will not prevent direct coupling. It will not prevent direct application. It will not prevent antenna coupling, for example. So it can also come an SBA. Okay, antenna coupling is something that is outside our field. It's not going to hurt the patient whatsoever. Okay, it has something to do with the emitted electromagnetic waves, and it will be collected by an outer side device. So this is something that will be outside the surgical field. So we don't have to worry about it. Direct coupling. What is direct coupling? When the active electrode touches another metal instrument by mistake. This is direct coupling, not direct application. So, for example, you are having a scissors over the abdomen of your patient, and you are doing diathermy, and the diathermy is still on. When you put it aside, it touches the scissors, so the skin is burned. If we are talking intra-abdominally or laparoscopically, this can happen, yes. If you are working with the diathermy and you have touched the forceps on the other port by mistake, this is direct coupling. Okay, capacitive coupling, as we said, it is about the energy that is collected up between the two materials of the port. This is why hybrid cannulas is not advocated. Hybrid cannulas means that you have a metal cannula with a plastic gripper. This is how the energy is going to collect between those different physical materials. And then when you turn up your diathermy, this energy is going to escape and go to any nearby cooled instrument or any nearby organ. Any nearby organ is going to absorb it. So if we need to prevent such complication, how I'm going to do this? I won't use hybrid cannulas. If I'm using hybrid cannulas, I have to make sure that I'm not nearby any bowels or vital structures, which is very difficult, by the way. Or I will not activate in open circuit. Or I'm going to use the cut mode instead of the coagulation mode. Why? Because the cut mode is using lower voltage. So at least I'm not going to have a very high power collected energy in this place. Or I have to make sure that I'm not close to any metals in the operative field. Okay, so here again, this question, as I told you, this one is important. The AEM that I have talked about a minute ago, this is going to avoid the injuries of insulation failure and capacitive coupling. But there is something called this adaptive electrosurgical technology, this one. The one now that mostly used in surgical units do not detect insulation failure. But I forget about this. Stress over this. This can be an SBA. Okay. So now, yeah, here we are. This is the picture I wanted. Those are the zones of electrical pulse. This is very important, guys, if you are working in electrosurgery. Because zone 3 and zone 2 is outside your view. And here, between zone 3 and zone 2, this is the area where capacitive coupling happens. While zone 2 and zone 1 is the areas where insulation failure can happen. Is it now more clear? Okay, let's get back to how we can avoid the injuries. Because again, this is very important for your exam. Okay, we should inspect for any installation defects before we start. Best, we should use the lowest possible effective power setting. Okay, if you can use any new technology that can detect the failures, of course you should use it. If you need to choose between monopolar and bipolar diathermy, bipolar is better in many things, but it's not going to give us the cutting effect. So monopolar diathermy, especially in cutting, try to use the low voltage possible. What else? Use brief intermittent activation, not continuous activation. Do not activate in close proximity. And of course, not in direct contact with another instrument. So if you are using two instruments, make them apart before activation of diathermy, because this is very risky to have direct coupling or high amount of voltage or even lateral thermal spread. And make sure that the heels and tips of bipolar forceps are under direct view when you are activating it. Please don't forget that they are going to be hot even after the activation. Okay?